starting with realizes. So we're going to be talking a little bit about the prevalence and impact of trauma. So when we think about the definition of trauma, we know that trauma results from an events or a set of circumstances. Trauma is not a diagnosis. It's something that happens to somebody, and there can be multiple consequences of that. When people are exposed to a traumatic event, they experience that event as harmful or life-threatening. And the impact can be a lasting adverse effect on a person's functioning in terms of their mental, physical, social, and or spiritual well-being, that it's a holistic experience with multiple impacts. There are different types of trauma exposure and categories of trauma exposure that people can experience. One being intergenerational and historical trauma. Intergenerational trauma impacts both the individual and the collective health of communities and systems. And so intergenerational trauma, as it sounds like, is trauma that is transferred between generations through epigenetics and behavioral exposure. So there's something that's when a parent is exposed to a traumatic event, the physiological changes that they experience can be passed through them biologically through epigenetics. And then those things can also be acted out in terms of the things that somebody is exposed to, their attachment, their ability to attach with the caregiver, other stressors that are ongoing that might have implications or increase the risk of exposure to trauma or the severity of that exposure. Historical trauma is a type of intergenerational trauma in which a cultural group share a trauma that is experienced across someone's life and across generations. So even if they don't have an explicit knowledge or they haven't explicitly been exposed to the thing, through the legacy of that impact, are experiencing different adverse impacts of those events. So, for example, the multi-generational, intergenerational impacts of things like slavery, oppression, racism, genocide, loss of language, persecution, natural disasters, pandemics, restrictions of rights that have these domino effects on somebody's individual well-being, how they operate within their family, their social network, their community, and how those communities function both psychosocially, but within the built world as well. Access to resources, think about things like social determinants of health. We also know that discrimination and marginalization itself can be traumatic and cumulative. And this is something that I think is under-researched in when we're thinking about applications of some of the traditional treatments that I've talked about, things like prolonged exposure or cognitive processing therapy, for example. But there's been a growing effort to think about appropriate adaptations and approaches to treatment for these types of traumatic stressors. So we know that acute and chronic exposure to marginalization can induce symptoms similar to PTSD. And that can cross somebody's intersectional identities. It can be gender, race, religion, age. There's so many different components of immigration status, language that can increase somebody's exposure to marginalization and induce symptoms similar to PTSD. The complexity of this is that these types of trauma are also experienced vicariously by witnessing interpersonal or systemic violence, seeing other people like you who share your characteristics being harmed on the news, or other stories, or a friend or a family member, or in a workplace, or seeing the systemic impacts of the legal system, of the healthcare system that can, even when you're not directly exposed, message to you that you are unsafe in those systems because people like you are unsafe there. Exposure leads to non-pathological responses in those impacted. And so when we think about things like increased mistrust or increased safety behaviors, hypervigilance, those reactions in and of themselves may not be pathological based on that person's context and experiences, right? So we also have to be really mindful as clinicians that when somebody is coming to us who has experienced significant discrimination and or marginalization and is talking about difficulty with trusting or feeling really anxious to go into work, because of fear of how they're going to be treated, that being able to really contextualize that within their experience and the system's interaction with them is really crucial, and that we're not just kind of labeling it as, pathological anxiety or paranoia or other things that maybe wouldn't consider the context as well. Discrimination-based traumas can be external, things that are happening outside that you are being impacted by, but also internal, such as internalized stigma or stress related to concealing one's identity. For example, I work with a medical trauma, and so one that comes up a lot is internalized ableism. This idea that if I am no longer able to use my body in the way that I am, or my chronic illness keeps me from working, that I'm not valuable to my family, that I'm not valuable to society, that there's no point for me to be here, right? Those are ingrained, internalized beliefs about your value, your intrinsic value as a human being because of your physical ability. And you can imagine how these internalized stigma can cross-cut, again, people's multiple intersecting identities. When we think about adverse childhood experiences, this is really a foundational premise of trauma-informed care. You often don't hear people talking about TIC without talking about ACEs. And so there are different types of ACEs experiences, kind of broken down into big bucket categories: abuse, neglect, and household dysfunction. Things like having somebody in the home with mental illness, untreated mental illness, having a loved one who is incarcerated, bearing witness to a caregiver being treated violently, substance use in the home, divorce, separation. And again, that there's been more recent expansions in thinking about applying a culturally humble lens to ACEs and thinking about things, the other types of ACEs that exist, things like immigration, parental separation that can occur as a result of that, some of the discrimination and marginalization that we talked about on the prior slide. What we know is that as the number of ACEs increase, so does the risk for negative health outcomes. And so we can see this cumulative effect of trauma exposure. Some of the outcomes that have been associated with ACEs can be showing up in changes in behavior and also in health. When ACEs was first coming out, and there was a conversation of like, oh, people who have high trauma exposure have high ACEs, they lack they're not engaging in physical activity, they're smoking more, they're drinking more, they're using drugs, they're missing work, and it's leading to all of these negative physical outcomes. There was a lot of conversation around, oh, well, that's because they're engaging in these risky behaviors. Yes, of course, if they're drinking more and using drugs, they're going to have these negative health outcomes. And what we've actually discovered over the years is that trauma in and of itself, even when you're controlling for other risk behaviors, directly impacts our physiological health, which makes sense when we think about the impact of trauma on our central nervous system and our immune functioning, the way our physiological state, right? That can increase the risk for things like heart disease, stroke, stress related things, high blood pressure, et cetera. So when we're thinking about kind of summarizing the impact of these types of trauma exposure, I think it's helpful to look at this pyramid where we kind of see the foundation of intergenerational historical trauma at the base that, as a result, changes social conditions, which then increases the risk for exposure to adverse childhood experiences, that then has impacts for disrupted neurodevelopment, and then social, emotional, and cognitive functioning. When people are trying to manage a dysregulated system, they do sometimes engage in health risk behaviors as a way to try and manage and tolerate this distress. That ultimately can contribute to disease, disability, and social problems. And that's where we usually come in as therapists, right? Is that we're kind of getting the watershed impact of all of this history, both the individual's history, but also their intergenerational history, their societal history, their community history. And ultimately, we know that trauma can contribute to early death because of all of these things. And so it's imperative, again, to think about addressing trauma as a public health concern, and that this is cross-cutting domains and not something that should just be siloed within mental health care. So when we think about the intersection of community and healthcare, including mental health care, is that in our community, most people are going to be exposed to at least one traumatic event in their lifetime. Many people, though, are going to have multiple exposures or experience chronic trauma. We know that health is wealth and that many trauma-exposed people have unmet basic needs. And I'm sure that many of you are familiar with that in terms of your settings, is that these experiences don't come alone, right? There are lots of other psychosocial stressors that come along with it that exacerbate, compound trauma exposure. As a result, many people face significant barriers to good health, physical and mental health. And that chronic exposure to dehumanization, oppression, discrimination steals health and wellness from our communities. And then this intersects with the healthcare system. Healthcare systems are a microcosm of these disparities, right? If we're thinking about people who are most burdened by chronic trauma, most impacted by negative social determinants of health, what do we also know about the systems that they have access to? They're under-resourced, they're understaffed, they don't have the same specialists, they don't have the same access to routine sessions, to all of the things that we would hope for in terms of our own health and the people that we care about. These systems are more likely to be impacted by system strain, lack of resources, staffing that impacts both patients and clinicians, right? We are also operating within these systems. And we know, or maybe you've been in places before where there's so much pressure to get people through, to add more and more people to your caseload, that crushes you as a clinician and has negative impacts for patients as well. Oftentimes when our patients are interacting with the healthcare system, these treatment experiences can elicit fear, shame, guilt, anger, helplessness, and perpetuate this cycle of avoidance and conflictual engagement with the healthcare system, right? Only engaging when things have gotten so bad that we need to. And then as a result, the care received and the approach to that can be really challenging. We also know that our systems of care aren't really built or incentivized to address barriers to health and wellness, right? Think about insurance payments. Think about all of the hoops that we have to jump through in order to provide the type of care that we know that our clients, our patients need, right? So there's these systemic strains on us as providers that have significant implications for our clients as well, trying to get them connected with social services, all of the hoops that people have to jump, the multiple attempts to get disability benefits. There's so many pressures and structures that are occurring. And so that has an impact on us as clinicians. Hopefully we come into this work really motivated to help other people. And when we get into these systems and we realize, there's a lot that I can't fix here. There's a lot of significant impacts that, this person needs a roof over their head. We can work on coping in these things, but the thing that's going to drastically improve their life is having stable access to housing, to food, to healthcare. And that can feel really overwhelming as a clinician. And so we ourselves can be exposed to different types of workplace trauma. Things like secondary traumatic stress, vicarious trauma, compassion fatigue, and burnout.